Hello. Hi everyone. Gosh, so sorry for the fact that this did not work the last time. I'm really hoping that it's actually working this time, but I'm not really sure how to make sure that everyone can hear me. And
We can hear
awesome,
you.
awesome. Okay, so thank you so much for joining once again, and I'm so sorry to have put you through this once again. Um, Again, for those who don't know me, my name is Dr. Kristina Sule. I'm a consultant obstetrician and gynecologist. I run my private practice. It's called Allora Medical Practice, and it's on Hospital Road. Yeah, thank you all for joining, and also follow us on all our social media pages, Facebook and Instagram. And so I'll just get right to it because we're a little bit late. We're running about 10 minutes late on time. So we'll just have a brief discussion, and then I will give you a chance to ask questions. So basically what we're going to talk about is abnormal menstruation, but specifically I'll speak more about painful menstruation. There's a lot to say about abnormal menstruation, and I'm not going to be able to cover all of it. So I'll speak about painful menstruation, and then I'll also talk briefly about PMS, premenstrual syndrome, and then we'll also talk briefly about the effect that contraception has specifically on menstruation. So just a disclaimer, for those who joined the meeting, not everybody has a medical background. So I'm just going to alternate medical terms with non-medical terms. I'm just hoping that everyone will be able to understand. And then if you have any questions, we'll have a short session at the end where you can ask questions. And if you don't get to have your question answered, you can always DM me on our Instagram page. That's Allora Medical Practice, or my personal page, Instagram page, which is Dr. Kristina Sule, or even on Facebook. So just to get right into it, so for us to be able to understand what abnormal menstruation is, we need to first understand what normal menstruation is. And a normal menstrual period is one that is a cycle between 21 and 35 days. So if your cycle is less than 21 days or over 35 days, then that's actually, strictly speaking, not normal. But a normal cycle is between 21 and 35 days. It lasts between 2 and 8 days. And the amount of blood that you should ideally have is around 80 ml. Now, most people do not quantify the amount of blood that they have. You know, no one goes measuring it, except for people who use a menstrual cup. Those are people who can actually say that this is the amount of blood that I have had during my menstrual period. Otherwise, you're usually not able to quantify the amount of blood, but when you describe it to your gynecologist, they're able to judge around how much it is in terms of the number of pads or the number of tampons that you use. So 21 to 35 days, between 2 and 8 days duration, and about 80 mLs. So then in that case, what is abnormal menstruation? So the abnormalities can range in terms of the regularity, in terms of the duration, and in terms of the amount. So in terms of regularity, if you have a period that is irregular, meaning there are months that you don't have a period, or there are months that you have more than one period, or in between two periods you get a time where you have spotting, then that's considered abnormal menstruation. And that's in terms of regularity. Now, in terms of duration, if you have a period that's less than 2 days, or lasting more than 8 days, then that's ideally considered abnormal. Although there are women who have that kind of period, and it doesn't really cause them any kind of distress in terms of ability to get pregnant, or they don't have any pain. They're able to maintain a good hemoglobin. So strictly speaking, it's between 2 to 8 days, but there are those who have more than 8 days, and it's actually quite okay for them. And then in terms of heaviness, again, we said it's around 80 ml. However, for those who tend to use very many pads, or those who tend to bleed less than one day and use maybe only one or 2 pads a day, that's strictly speaking an abnormality. So we've talked about the duration, the heaviness, and also the regularity. But there are other symptoms of abnormal menstruation that are not to do with the heaviness, the duration, or the regularity. So there are those women and girls who tend to have severe headache. There are those who tend to have vomiting. There are those who tend to have diarrhea. There are those who have syncope, or they tend to, faint or pass out. There are those who have lower limb swelling or severe back pain. Some even have lower limb numbness. Some even have convulsions. And so all those are considered abnormal symptoms that are related to menstruation, and they definitely need to be investigated by the gynecologist. But the one symptom that I really want to focus on is pain. And so painful menstruation is ideally called dysmenorrhea. And we have 2 kinds of dysmenorrhea. We have primary dysmenorrhea and secondary. So primary dysmenorrhea is generally dysmenorrhea. So first of all, just to mention, pain, periods are meant to be painful. They're uncomfortable. It's blood trying to escape the body. It's trying to get through the cervix. So you're going to experience some form of discomfort, but the pain should not be severe. It should not be debilitating. It should not be pain that, distracts you from your daily activities. So primary dysmenorrhea is generally experienced earlier in life, from the time a girl starts her periods, which is menarche, and then going later on into life. And so the earlier it is, the more likely it is to be primary dysmenorrhea. Sorry, I'm just going to try and mute this person here. Am I able to do that? Thank you so much. Thank you. Okay, so as I mentioned, primary dysmenorrhea, it happens mostly in adolescence, and it's the dysmenorrhea that actually has no diagnosed pathological condition. So it happens earlier in life, and it's basically where a doctor has not made any diagnosis in terms of something being wrong with the menstrual cycle or the uterus or the ovaries or any other reproductive organ. So there's no pathological identifiable lesion, and also it happens earlier on in life, from the time of menarche, before regular menstruation is established. So there's a number of causes why women could have, or young girls could have, primary dysmenorrhea. And many of them are just about the establishment of the reproductive system. So one of them could be that the autonomic system of the uterus is still immature, and that could cause quite a bit of pain. Some of the symptoms could be psychosomatic. So when a girl starts her periods, she could generally be in a lot of distress and anxiety, and that could actually cause physical pain for her. The other thing is that when menstruation starts at menarche, there's something called uterine hypoxia, which means that the uterus is not well vascularized. It hasn't developed its blood system very well, and that could actually cause a significant amount of pain. The other thing is that you could have uterine anomalies or reproductive system anomalies that are congenital, meaning that you are born with them, that could cause quite a bit of distress and pain, which is the reason why when there's severe pain during menstruation, you generally need to see a gynecologist, because it could be any of these reasons and they need to be able to diagnose the condition for you. So in terms of the congenital abnormalities, you could have a septum in your uterus, you could have a biconjugate uterus, so meaning it has more or less 2 large chambers, and that abnormal shape can ideally cause a lot of pain during menstruation. There are women and girls who have something called a hypoplastic uterus, meaning that it's smaller in size than a normal uterus at that age should be, and that could cause a lot of pain. There's some women and girls who have cervical stenosis, meaning that the cervical canal is extremely narrowed, meaning that they're not able to menstruate freely, and that causes a lot of pain because the blood just generally gets more or less stuck within the uterus. It's not able to come out. So all these congenital anomalies could actually cause quite a bit of pain during menstruation. Now, for primary dysmenorrhea, there are several, kinds of treatments that can be offered. So some of them include like exercise. So exercise has been shown to improve dysmenorrhea. Some of them is just really plain reassurance, especially for those who have psychosomatic features and psychosomatic kind of pain during menstruation. Most of the time, just reassurance is sufficient. For some, even things like herbal medication has been known to improve, or herbal teas such as mint and chamomile, they've been known to improve primary dysmenorrhea. Some people have even suggested things such as acupuncture. Now, I'm not a herbalist and I'm not an acupuncturist, so I can't really vouch for these methods as a way to improve dysmenorrhea, but it has been documented, although extensive studies have not been done. So for me, what I basically recommend is more of a pharmacological treatment for primary dysmenorrhea. Now, there's several options. One of them is non-steroidal anti-inflammatories, or NSAIDs, drugs such as ibuprofen rather, diclofenac, and so on and so forth. And these are known to improve primary dysmenorrhea quite a bit. Other options is like prostaglandin synthetase inhibitors, such as mefenamic acid. So that tends to improve dysmenorrhea quite a bit. And then one of the favorites of gynecologists is the oral contraceptive pill, the combined oral contraceptive pill, because certain hormones, for example, estrogen and progesterone, are required to make the reproductive system mature. And so when we give an iatrogenic or an external oral contraceptive pill, it allows the reproductive system to mature. And at the same time, it almost programs the reproductive system and the ovaries and the hypothalamic pituitary ovarian axis. So it tells our system, this is how much estrogen you need to be producing. This is how much progesterone you need to be producing. And so we take the pill for about 21 days, and then we have a 7-day pill-free period where we're allowed to menstruate during that period. And so that's basically how it works in terms of decreasing the pain. Now, we also have things like surgical methods for primary dysmenorrhea. So for girls who have an abnormally congenitally shaped uterus, so you're born with an abnormally shaped uterus or any other congenital anomaly, that can be corrected surgically in order to improve the dysmenorrhea. So for example, if your cervical canal is very narrow or stenosed, then you can have it surgically widened. There are some people who have to go even as far as neurectomy, meaning there are certain nerves that innervate the uterus and the pelvis that have to be transected because the dysmenorrhea is very severe. So that's basically about primary dysmenorrhea. Now, secondary dysmenorrhea is dysmenorrhea where it was either previously not there or now a pathological entity has been identified. So basically, these are women who have uterine fibroids, endometriosis, pelvic inflammatory disease, adenomyosis, uterine polyps, or other cervical infections and issues that could be causing severe dysmenorrhea. And these are basically diagnoses that are made by gynecologists. Now, why I'm insisting that you must see a gynecologist when you have such conditions is because you do not know whether you have primary dysmenorrhea or secondary dysmenorrhea. And there are several studies that have been done, including studies in Kenya, that show that endometriosis is something that affects even very young girls as early as menarche, as early as the age of 12. There are studies that have been done that have shown that the severe dysmenorrhea that girls experience can actually almost be directly attributed to endometriosis. And as you all know, endometriosis is basically where the lining of the uterus escapes the uterus and now goes to a new site, such as the ovary, the top of the uterus, the bladder, the rectum, or any other site. It could go to somewhere as ectopic as the lungs or even the brain. And when it goes to this new site and the hormonal composition is correct and the time of the month comes, then it ideally bleeds in this new site, and it causes a lot of pain and inflammation and scarring in that new area, which is basically what contributes to the severe dysmenorrhea. So all these conditions need to be diagnosed by a gynecologist and they need to be treated. And so, don't take dysmenorrhea lightly. You would rather have your gynecologist assure you and say, look, this pain is something that can be managed, with an NSAID, there's nothing to worry about, then, get to the age of 30 and then discover that you actually had a congenital uterine anomaly, which was causing you so much pain. Okay, so that's basically about dysmenorrhea. And so now we will quickly go into the premenstrual syndrome. So premenstrual syndrome is a psychoneuroendocrine disorder, meaning it has a psychological or a psychiatric aspect. It also has a hormonal aspect to it. And that's why diagnosis of premenstrual syndrome is a very difficult diagnosis. It's actually included in the DSM-4 and 5, which is basically where psychiatric disorders are described. So it's basically something that requires a team management between a gynecologist and a psychiatrist. And there's basically 4 main criteria that are able to tell that this is actually premenstrual syndrome and nothing else. And so one of them is that the gynecologist must be able to rule out that there's no other pathological reason or diagnosis that could be causing the symptoms of the PMS. So, for example, if you have a psychiatric condition or you suffer from bipolar or depression, then it becomes very difficult to diagnose PMS because it could be that the symptoms that you're facing, sorry, it could be that the symptoms that you're facing are because of the psychiatric disorder that you're having. So number one, there should be no other pathological disease that is identified. Second thing is that PMS only happens during the luteal phase of the cycle, meaning that you must have ovulated first before you have PMS. So if the symptoms that you're experiencing come prior to ovulation or prior to the mid-cycle, that is not PMS. PMS only happens during the luteal phase of the cycle. The other thing is that the rest of the cycle, other than the luteal phase, needs to be absolutely normal, meaning that if you have symptoms in the first half of your cycle, that is not PMS, and also you have to be completely symptom-free in the time prior to ovulation for it to be diagnosed as PMS. And the last criteria is that the symptoms that you're receiving should be so severe enough to disturb your lifestyle, disturb your daily activities, and just generally the way you conduct your life. So if you just get a little bit moody around the luteal phase of your cycle, yes, it might be PMS, but it needs to basically be something that can completely disturb your lifestyle for it to be considered PMS and for it to warrant treatment. Now, there are several symptoms of PMS, and they're basically attributable to 3 main things. Some of the symptoms are attributable to water retention. Other symptoms are attributable to behavior. Oh, sorry, you can't hear me. Let me just increase the volume. Can you hear me now? Am I more audible? Barbara, maybe you can tell me if everyone can hear.
We can't hear you well.
You can't hear well? Okay, let me just try and adjust my volume. How about now? Should I speak a bit louder? Is it better?
Yes, much better.
Better, yeah? Okay, let me get closer.
Yeah, that's okay. We can hear.
Okay, let me get closer to the camera. So I was saying that the symptoms of PMS can be attributed to 3 main factors. One of them is water retention. The other one is just behavioral symptoms, and the other are neuropsychiatric. So the symptoms that are attributable to water retention are like breast tenderness, lower limb swelling, and weight gain during menstruation. And then the ones that are more attributable towards neuropsychiatric issues are like anxiety, tearfulness, increased appetite, irritability. So basically, we need to understand PMS very well. Just because you're irritable during your period doesn't mean that you have PMS. And it's actually really unfair to tell someone that you have PMS because you're irritable, because sometimes it's just pain. Sometimes they have a neuropsychiatric disorder that could be causing the symptoms. And then finally, those that are attributable to behavioral symptoms are like dyspareunia, tiredness, fatigue, and so on. And so there's a way to confirm PMS, that one has PMS. And one of the confirmatory tests that we do for PMS, other than the core criteria that I mentioned before, is to give gonadotropin releasing hormone analogs. So they usually come in an injectable form, and they're given at once a month injections for 3 months. Now, most of the time when a person receives gonadotropin releasing hormone analogs, they get amenorrhea, so their periods disappear. So that's going to happen. Doesn't happen for everyone, but for majority of people. So once the period disappears and the symptoms of PMS disappear, then you can make a confirmatory diagnosis that, this actually was PMS once you've ruled out the 4 criteria. And so what are the treatments then available for PMS? So we have some treatments that are completely non-pharmacological, and then we have those that are pharmacological but are not hormonal, and then we have hormonal treatment. So of the non-pharmacological treatments, one of them is just, again, as I mentioned, exercise. One of them is reassurance. And another one is modification of diet. So diet modification will include avoidance of caffeine, avoidance of excess alcohol, and of course, certain dietary modifications. It has been proposed by certain people that PMS happens due to vitamin B6 deficiency. So one of the dietary adjustments that can be put in place is to increase the amount of consumed vitamin B6. And then of the pharmacological treatments, in terms of non-hormonal treatments, most of the time those treatments are just targeted to managing the symptoms. For example, if there's breast tenderness, one of the treatments that you can get is bromocriptine, and that really helps with breast tenderness during PMS. Another thing that you can consider is the diuretics, which basically improve the water retention aspect of PMS. Something else that's given is like pyridoxine for those who have vitamin B6, who are suspected to have vitamin B6 deficiency in PMS, and that really helps. One of the other drugs that is used is selective serotonin reuptake inhibitors, but I personally have an issue with that because if you give someone a selective serotonin reuptake inhibitor, which is basically a psychiatric drug, then that means that you have not necessarily ruled out a psychiatric condition, which means that you have not met the 4 criteria to diagnose PMS, which means that basically this is just someone with probably a psychiatric disorder that's not actually having PMS, but some people still use it as one of the drugs to treat PMS. Now, of the hormonal medications, one of the ones used is oral contraceptive pills. They're actually known to really improve the symptoms of severe PMS because they have estrogen and they have progesterone, and sometimes the estrogen and progesterone tend to be unbalanced in people with PMS, especially during the luteal phase of their cycle. So that generally brings about the balance back. Another hormonal drug that is used is, as I mentioned, the GnRH analogs, so they can be used during PMS. Drugs such as goserelin, triptorelin, and leuprolin can also be used. Some people prefer to use drugs like danazol, but for me, I feel like that's really extreme to treat PMS, although there are those who have very severe symptoms and they actually do require these drugs. So that's basically about PMS. In case you have any questions, you can just drop them. And so now I'll just tell you really quickly about the contraceptive effect on menstruation. So contraception really does affect menstruation in a number of ways. One of them is oral contraceptives. So what effect do oral contraceptives have on menstruation? They actually have a really good effect on menstruation. They tend to regularize menstruation. So for those who have irregular menstrual cycles or those who have dysmenorrhea due to hormonal imbalance, they can get oral contraceptive pills, and it basically programs the body on how much hormone it needs to be producing and how the cycle should be. So again, as I mentioned, it's the 21-day pill period and then the 7-day pill-free period. And that's usually given for 3 to 6 months. Now, just to mention, if one has a menstrual irregularity and they are prescribed an oral contraceptive pill, taking it for 1 or 2 months is not going to cause regularity. It's not going to improve dysmenorrhea. It needs to be taken for a minimum of 3 months, but usually 6 months or even more for you to notice, good improvement in the regularity and in the dysmenorrhea. So aside from causing contraception, that is a non-contraceptive benefit that oral contraceptive pills have. Now, the second one is still an oral contraceptive, but it's the e-pill. So the e-pill is the emergency pill. It's usually progesterone-based, but there are some emergency pills that have both progesterone and estrogen. And then there's a newer emergency pill called Ulipristal. It's not readily available in Kenya, but it's very effective. It's available in the West. It's actually more effective than the progesterone-based emergency pill that we have here in Kenya. And so basically, I want to answer a few questions that I usually get about the e-pill. So first of all, the e-pill does not cause problems with future fertility. Most people think that, if I take the e-pill, then I'm going to be infertile later on in life. That's absolutely not true. There are many studies that have been done to that effect that the e-pill does not cause problems with future fertility. The other thing, it also does not predispose you to ectopic pregnancy. Neither does it predispose you to getting pelvic inflammatory disease. Now, the problem with oral contraception is that many women who are on oral contraception tend not to have dual contraception, meaning they do not use barrier method, they do not use condoms, and then they tend to get pelvic inflammatory disease from STIs and other sexual contact. So the oral contraceptive pill on its own does not give you pelvic inflammatory disease. It's just that most women who are on oral contraceptive tend not to use a barrier method in addition to the oral contraception. So it's actually quite safe. Now, one of the things that the e-pill can do to your menstrual cycle is that it can make it irregular. Usually this irregularity does not last beyond 1 or 2 cycles. However, the problem that it can cause is for those who use the safe day method, once your cycle is disturbed by the e-pill, it becomes difficult to tell which ones are your safe days, which ones are not. So getting pregnant after that can get easier, which is probably not what you're looking to do. Now, again, for people who actually are looking to get pregnant and have recently used an e-pill, when it makes your cycle irregular, it becomes difficult for you to predict. I've been told to move nearer to the mic. It becomes easier for you to, it becomes more difficult for you to predict when you ovulate and when you can get your menstrual cycle. So for those looking to get pregnant, it becomes a little bit more difficult. For those not looking to get pregnant, it becomes easier, more or less, to get pregnant after the e-pill. So it causes menstrual irregularity. It can also cause a bit of nausea, but other than that, it does not have lasting effects. Now, the other form of contraception is the copper IUCD, or intrauterine contraceptive device. So the copper IUCD can have a number of effects. One of them is menorrhagia, which is increased menstrual bleeding. So your cycle could tend to be a bit heavier than what it was before. There are studies that have been done that show that having a copper IUCD can increase the vascularity of your uterus, and that's probably what causes the bleeding. It can also cause inflammation. It's a foreign body within the uterus, and actually its contraceptive effect is because of inflammation, so that could also increase the amount of bleeding. So basically, you're going to get heavier cycles. You can also get intermenstrual bleeding or spotting with the copper IUD. It's actually very common. Also, you can get a lot of dysmenorrhea with the copper IUD because it's a foreign body. The uterus tends to contract a lot to try and expel it, and that can cause quite a bit of pain. So that's the effect of the copper IUCD. Now, I'm just going to put on my microphone because I can hear my daughter coming into the room. Sorry, Hello, can you still hear me? Can everyone still hear me? Please let me know if you can hear me.
Yeah, the mic is now perfect. Thank you.
Okay, excellent. Right. Okay. Thank you so much. So, yes. So I've mentioned about the combined oral contraceptives and the copper IUCD in terms of the effect that they have on menstruation. Now, the other thing, and the e-pill as well. The other thing is the progesterone-based contraception and the effects that they have on menstruation. So generally, what progesterone does to the reproductive system is that it causes the endometrium or the lining of the uterus to be really thin. The work of progesterone is to thin out the endometrium. Remember, progesterone is the pregnancy hormone, and during pregnancy, you should not be having, a thick endometrium. So once it thins out the endometrium, that basically causes the contraceptive effect. So the endometrium is so thin that actually implantation cannot happen. And of course, having a thin endometrium, which is what gets shed during the menstrual cycle, can cause can cause amenorrhea. So basically, your menstrual period could be completely absent, or it could be extremely light, or you could just have spotting, and that's basically exactly what progesterone-based contraception does. Whether it is the progesterone-based IUD, which is called the Mirena, whether it is the depot progesterone injection, the 3-monthly injection that can cause the same symptoms, whether it is the oral progesterone pill, all those cause the same effect. They cause the lining of the uterus to be really thin. They cause either amenorrhea or very light menstruation or spotting, and they cause a lot of irregularity. Oh yeah, and that includes the progesterone implant, which is the Jadel or the Implanon. So all those can give you menstrual irregularity, can give you spotting, can give you amenorrhea, complete absence of the period. At the same time, progesterone-based contraception can be used to improve dysmenorrhea, because if the period disappears, then of course you cannot have dysmenorrhea. At the same time, if the lining gets really thin, it becomes very easy for the uterine contractions to expel the little remainder of the lining that's left, and so dysmenorrhea really improves with progesterone-based contraception. So I hope I've managed to answer a lot of your questions that you may have had in your head about the effect that contraception has on menstruation, and also about PMS and abnormal menstrual bleeding. And so now I will just take a few questions, and then we can conclude. So I'm not really sure how I'm going to take the questions. I don't know if you'll actually ask them. I can see a chat box.
Yeah.
Okay,
There's
let me
one
just.
question.
Yes, go ahead.
There are two from the chat box. The first one is, what about the next plan-on implant for 3 years? They're asking about. Someone is asking about it. Like, what is its effect?
So the next plan-on implant, the next plan-on or implanon. So next plan-on is not very common in Kenya. Implanon is more common, and Jadel, they're more or less the same. Basically, that is a progesterone-based contraception. It's one silicone stroke plastic rod that's inserted subdermally. It lasts 3 years. It releases a small amount of progesterone every day for 3 years. The effects that it causes on menstruation is that your period could disappear completely. As I mentioned, with all progesterone-based contraception, you could have amenorrhea, you could have very light menstrual bleeding, you could have irregular or erratic spotting. Those are some of the things that you can get. Ideally, most of the time, it does not cause dysmenorrhea. So those are the effects on menstruation. Of course, it has other effects on the body, like weight gain, acne, low libido, headache, and other effects. But on menstruation, mainly it's irregular bleeding, spotting, and amenorrhea.
Okay. And someone else is asking, what would you advise on to get? Is it Implanon or copper IUCD? And which one of the two is cheaper?
Contraception is a very, very personal choice. It's really up to you and also your sexual partner. There are women who, for example, get the Implanon and then their libido becomes so low that literally they're brought by their partners and their partners are like, get this thing out. So it's a really personal choice. I cannot tell you which one is better. There are those women who have such heavy menstrual bleeding that they literally cannot have a copper T, because if their bleeding gets worse than that, they'll have anemia. So they must get a progesterone-based contraception so that the bleeding can decrease. So there isn't one that's better than the other. It's a lifestyle and a sexual partner choice. In terms of what is cheaper, it depends on the facility that you go to. In many private facilities, subdermal implant is the same price as a copper T. Actually, even in many government facilities, it really depends on the facility that you go to.
Okay. And then another person is asking, Haley, she's asking, what's your take on narcotics for treating dysmenorrhea? Like, what's your take on that?
I would say I'm against narcotics for treatment of dysmenorrhea. Mm-hmm. By the time you're taking codeine-based medication for dysmenorrhea, that is severe dysmenorrhea, you need a proper diagnosis. Like, is it endometriosis that you have? Is it uterine fibroids? What exactly is going on to cause that kind of pain? Because you're supposed to feel minimal discomfort, and at most, something like an NSAID should be able to sort it out. By the time you're getting parenteral medication like an injectable, an IM, an IV, analgesic, codeine, or any other narcotic, really the dysmenorrhea is too severe and you really need a diagnosis and a treatment. So I'd say no.
Okay. And what is vicarious menstruation? I don't even know if that's how it's pronounced.
Sorry?
Vicarious menstruation. VICARIOUS.
I don't know. I honestly don't know. I'm going to honestly, I have no idea. I'm going to assume that it's so there's something called concealed menstruation. Like, for example, when girls have an imperforate hymen, and then they menstruate, and so they develop abdominal swelling and severe pain, especially, it's a cyclical monthly pain and abdominal distension because the uterus gets larger and larger, and then they have hematometra. And so when it's actually diagnosed, there's an incision that needs to be made on the hymen for those who have imperforate hymen to allow all that menstrual fluid to come out, and also ensure that their cervical canal is patent so that they can continue menstruating and in future they can get pregnant. That's what I'm thinking it is, although I could be completely off because I haven't heard of it.
Okay. Then Humphrey is asking, in your experience, which are the best hormonal and non-hormonal contraceptives?
So in terms of So in terms of non-hormonal contraception, it's either condoms or IUCD, or copper IUCD, or abstinence. There's no other non-hormonal contraception available, and of those, I can't really tell you which is better than the other. For some, the copper IUD works very well, but for some, condom use works very well. For some, their partners will decline condom use, which is actually very wrong, because ideally you should use a condom no matter what contraception you're on. So those are the non-hormonal ones. It's difficult for me to say which is better, which is not. For example, if you have a latex allergy, then really a latex condom is not for you. So that's one thing. Now, in terms of the hormonal ones, let me not say what is the best, but for me, a good contraceptive is one that gives you non-contraceptive benefits. And one of the non-contraceptive benefits includes treatment of dysmenorrhea or treatment of irregular menstruation. So one of the hormonal contraceptive that I find gives the most non-contraceptive benefits is the Mirena, which is the hormonal IUCD. So basically, not only does it treat heavy menstrual bleeding, it makes the menstrual bleeding very light, it treats dysmenorrhea, it treats endometriosis. It's even suggested as one of the treatment for uterine fibroids. It can be used to treat endometrial hyperplasia, which is when the lining of the uterus gets very thick because of hormonal imbalance. So you see, it gives you a lot of added benefit. So in terms of the hormonal ones, and one other thing is that the hormone release remains only within the uterus. So the hormonal release does not go to the rest of the body. The progesterone is contained within the uterus. So it does not give you things like acne, low libido, weight gain, headaches, and all that. So it gives you minimal side effects with the maximal contraceptive benefit. It's 99.99% effective, and it has a lot of non-contraceptive benefits. So in terms of hormonal contraception, I would say the best is Mirena.
Okay. And Sarah is asking, does diet affect menstruation?
It affects menstruation a lot. Some people improve their diet and they notice a lot of improvement in terms of dysmenorrhea. How diet affects menstruation is in different forms. One of them is that women who consume a high fat diet tend to gain more weight. Now, what happens with hormones is that estrogen is converted to testosterone and vice versa in fat tissue. So the more adipose tissue you have, the more the conversion happens. And so women who weigh more and have more fat tissue are more likely to get things like polycystic ovarian syndrome, insulin intolerance, and so on and so forth. And with polycystic ovarian syndrome, you get oligomenorrhea, or very light and infrequent periods. So, and that's just one way that diet affects menstruation. So I would say, avoid caffeine, avoid alcohol, avoid high fat foods, red meat. What else? Yeah, those are basically the things that affect the menstrual cycle.
Okay, thank you. Yodit is asking, what's the recommendation for menorrhagia and iron supplements?
So first of all, you need to get a diagnosis for the menorrhagia. By the way, the terms have right now changed. We used to call it menorrhagia, oligomenorrhea, amenorrhea, and all that. We have new terms that have been released. Menorrhagia is now called heavy menstrual bleeding. Oligomenorrhea is now called light or infrequent menstrual bleeding, and then amenorrhea still maintains, but it's mostly called absent menstrual bleeding. So for heavy menstrual bleeding, a diagnosis needs to be made. Are you having uterine fibroids? Are you using an IUCD? Are you having an endometrial polyp, for example, that could be causing the heavy menstrual bleeding? Because for heavy menstrual bleeding, most of the time there's always a diagnosis, unlike for light menstrual bleeding. So once a diagnosis has been made, then the treatment needs to be accordingly. Sorry, I didn't get the second part of the question.
The recommendation for menorrhagia and iron supplements.
Yes, iron supplements. So women who have menorrhagia, other than making a diagnosis and getting treatment, they should definitely be on iron supplements. So for example, if you have symptomatic uterine fibroids, you should have ideally a myomectomy, and then at the same time, you should have iron supplements. So for those who have heavy menstrual bleeding, I would say they should have iron supplementation once they've done, a full hemogram and they can tell what their hemoglobin is. So if you don't have iron deficiency anemia or your hemoglobin is normal, then even though your menstrual flow may be heavy, I would not recommend iron supplementation if your body is managing the heavy menstrual bleeding on its own.
Okay. So Mudhani is asking, what about dyspareunia? Kindly talk about some of the causes of dyspareunia.
Okay, that is beyond our discussion today, because we're talking about dysmenorrhea and not dyspareunia. Dyspareunia has very many causes. Some are psychological, some are infective, some are even congenital abnormalities. Some are even sexual dysfunction. There are some women who are unable to achieve lubrication during sexual intercourse. There's some who are unable to achieve arousal, and all that can cause dyspareunia. Some women have cervical or vaginal infections like vaginitis, cervicitis. Some women have pelvic inflammatory disease. Some women even have vaginal and rectal endometriosis that causes dyspareunia. So that is a completely different topic with different causes. I could talk about it for an hour.
Okay. Haley is asking, does the hormonal contraceptive increase coagulation of blood?
That's a very good question. So there are certain studies that have been done on the combined oral contraceptive and its ability to cause DVT. Now, the studies are classified into low quality studies and high quality studies. High quality studies include randomized controlled trials, meta-analysis, and such studies. And then you have lower quality studies such as cohort studies, prospective cohort studies, and so on. Now, the studies that have been done around combined oral contraceptives and their ability to cause DVT are very varied. The high quality studies, such as meta-analysis and randomized controlled trials, show that oral contraceptives do not cause DVT. But the lower quality studies show that they do. So it's one of those things, it's really about what your gynecologist will think about it. In my personal experience, I think that oral contraceptives do cause DVT. I know several patients who have been on oral contraceptives and have gotten DVT. However, it's very difficult to attribute their DVT directly to the fact that they were taking oral contraceptives. There are some people who are genetically predisposed to getting DVT. There are some people whose occupation is very sedentary. They tend to sit a lot. And so they are also taking an oral contraceptive. And so you don't know whether their DVT is coming because of their sedentary lifestyle or because of the fact that they're taking an oral contraceptive. So basically, let me just say it's inconclusive because the high level studies say that OCPs do not cause DVT, but the low quality studies say that it does.
Thank you. Sarah is asking again, does Implanon cause dysmenorrhea?
No, it does not. In fact, it can be used to treat dysmenorrhea.
Oh, okay. Thank you. Valkid is asking, for polycystic ovarian syndrome, do you recommend someone to be on the combined oral contraceptive for long?
So the combined oral contraceptive can be used to treat polycystic ovarian syndrome. However, it depends on what exactly you're treating. With polycystic ovarian syndrome, we have two forms of management. There's management for those who do not want to conceive and for those who do want to conceive. So you know that polycystic causes infertility. So for those who want to conceive, the line of treatment is completely different. For them, we usually give ovulation induction medication. So basically, we are targeting their ovary and we're trying to make them get pregnant. But there are those who have polycystic and they're not looking to get pregnant. So for those, we usually manage symptoms. What are the symptoms? You can get acne, you can get hirsutism, you can get central obesity, you can get oligomenorrhea, male pattern baldness, and so on and so forth. So for those, we manage their symptoms. Now, for those who get oligomenorrhea or infrequent menstrual flow with polycystic, sometimes we can give them oral contraceptive medication to be able to regularize their cycle because maybe that's the symptom that is causing them the most distress. So it can be used to treat polycystic, but it will not resolve the entire syndrome of polycystic. So for example, if you have acne, then the oral contraceptive pill is very good at treating the acne that comes with polycystic. But if your major issue with polycystic is, for example, obesity, then you're not going to use the oral contraceptive pill to treat the obesity.
Okay.
Am I making
you.
sense? I hope I've answered that question.
Okay, Lavin, this is the second last question. Lavin is asking, what do the various period blood colors say about one's health? Like sometimes they're brown, sometimes they're red. Yes.
Oh my God. That's a very good question. I've never actually thought about that very much. But something that I can say is this: if you have very dark menstrual flow, this is basically blood that has stayed in your uterus or in your reproductive system for a while. And so it might mean that it's not flowing at the rate that it should. However, throughout your, 3 to 7 days of menstruation, the blood changes. Sometimes it starts out dark and then you have fresh blood, because that's now when the arteries and the arterioles are open and they're able to, release the arterial blood. So you'll find it's bright red. And then the darker one sometimes can be venous blood, or it could mean that, the blood has stayed in the reproductive system and only now it's coming out. Now, in terms of pathologies, I'm not able to tell you that, if your blood is dark, then you have this condition, or if your blood is light, then you have this condition. It doesn't signify any pathological conditions. But it just represents how your body is physiologically reacting to the menstrual cycle. So it's either the arterial blood or the venous blood, or an inability of the blood to escape quickly from the reproductive system. I think that's how I can answer that question best.
Okay, thank you.
So it's a very unique question.
So Winnie is asking, is it true that people who have painful cramps will have easy contractions during labor when they're delivering?
No. No, it's not. I understand where that question is coming from, because it's like asking, does the uterus develop muscle memory? Meaning, like, if you have your uterus tends to contract a lot during menstruation, does it mean that now when you're having a delivery, you will have, very good contractions, and, there'll be more or less painless and you'll have a good delivery? It has absolutely no bearing on delivery. Something that I will mention, which seems a bit of a digression, for those women who have severe menstrual pain, if you'll be told that, after you have a baby, then your menstrual pain will get less. And sometimes that's actually true. But the reason why that happens is this. For a majority of those who have severe menstrual period, they tend to have endometriosis that is undiagnosed. Now, endometrial tissue tends to respond to estrogen, meaning that estrogen makes endometrial tissue expand and grow and form certain histological variations. So endometrial tissue grows through estrogen and it disappears with progesterone. Now, during pregnancy, the endometrium disappears and there's a high amount of progesterone. So remember, I mentioned that when you have endometriosis, one of the treatments is through progesterone. And so it's basically how the body treats itself for the 10 months of pregnancy. So you produce high levels of progesterone. Any endometrial tissue that you had gotten that had escaped the uterus and gone to any other area shrinks. And for some people, it even disappears. So you've treated the endometriosis using pregnancy. And then now after delivery, for some women, the endometrial tissue that was ectopic regrows. For some, it does not. And so for those women whom it does not regrow, it's basically like their endometriosis has been treated. And that's why after that, their cycles are painless after delivery. So that's just something that is important to note.
Okay. Then the last question. What does the presence of lumps, including lump size, indicate? This is from Joanne. Yeah. Maybe she could be... Maybe she could speak out and be a bit more specific. John, do you mind telling us?
Are you talking of breast lumps or blood clots in menstruation?
Joanne, maybe she could pick up or text in the chat box so that maybe blood clots in menstruation.
Blood clots, okay. Okay, so nothing. It doesn't signify anything. It just means that your body is able to coagulate blood, which is actually a good thing. Now, blood clots become a problem in menstruation when the clots are too large and when they are accompanied by severe dysmenorrhea. So if your clots are very big and now they're looking like chunks of liver, and also, of course, for them to be able to escape your reproductive system, they cause a lot of pain. That's something that needs to be looked into, and you need to get a diagnosis. But ideally, little clots of blood is absolutely normal during menstruation. Doesn't mean anything. And also, if you don't get those clots, that's still normal.
Okay, thank you. So yes, that was the final question. I think all the
Okay.
questions have been answered very well, and it
Okay.
has been a very it's been an enlightening session. Thank you so much, Dr. for taking your
Thank you
time
so much.
to
Thank you
educate
so
us.
much for joining, and I really appreciate you listening. I had so much fun telling you about this, and thank you for all your unique questions.
Yeah. So just so that you know, everyone, please fill in the feedback form. I had made a feedback form so that everyone can
Okay.
tell us what they think about the session. I'll be sending it to you, Dr. And we do look
Okay.
forward to having many more sessions with you, because this was personally I've learned a lot and I'm so grateful. I just thank you and may you be blessed. Yeah.
Thank you so much, and most welcome.
Okay. So I guess the session is
Okay.
over, right?
Yes. Okay. Thank you. Bye.
Bye.